interaction with a patient begins when they make an appointment. And we do try to collect as much information that is pertinent to the patient's problem even before they get to the office. What I want to learn as a physician is, well, is the knee pain from the knee or could it be from something else? So right away I'm thinking of the back as a potential problem, the hip as a problem, weak bones can be a problem, occasionally even a tumor can be an issue. So I want to have a broad picture of what's going on and really talk about the specifics of the pain with the patient. How about long car rides or when you're sitting for a long time period?
Yes, definitely.
Hurts? Mm-hmm. Okay, all right. And well, the exam portion is very important. Again, with the exam is I'm not looking at the knee, but we're looking at the patient's ability to balance, looking at the spine, looking at the hips, really watching the patient walk. There may be a foot problem that contributes to the knee, or there may be a hip problem that is actually causing the knee pain. So it's important to watch the patient walk. We see the knee under stress at that time and we can make decisions as to, oh indeed, the seriousness of the knee problem and look for other possible explanations of that pain. Then I'll hone in on the knee itself. One of the things that we're looking for is the range of motion of the knee. Is the patient holding the knee in a position because of pain or because of weak muscles? There may be tight muscles or tight fascia that's causing the problem. So we should be able to tell a lot from the patient walking. When I watched you walk, I didn't suspect any issues with alignment. Your hip movement is good and symmetrical. If we've made the diagnosis of arthritis, that means that the patient is missing material. So that is, to date, a permanent diagnosis. Although we have multiple treatments that help with symptoms, we don't have a treatment that's just going to replace the cartilage unless it's a very confined defect, not the kind of problem that we would see with arthritis. It acts as a pad, much like a sponge. So when one bone hits the other, pressure is applied, and then actually big molecules are pushed out or expelled, and then when the pressure is relieved, then the molecules come back in. So there's flow in and out of cartilage that gives it its shock absorbing capacity, and that's what you're missing. With arthritis, it's important to understand, one, it's permanent, and two, it's progressive, and then to devise a treatment plan specific to the patient. We'll start with non-operative modalities, but understand that often the problem is to the point by the time the patient makes an appointment that it's probably going to need surgery. Number one is weight loss, because the knee is under a lot of stress when we get out of a chair, when we go upstairs, or if we run or even walk fast. Some of the forces are 10 times the body weight. So losing 1 pound is like losing 10 pounds to the knee joint in a lot of stressful situations. So weight loss, it doesn't have to be a lot to make a significant difference. Regular exercise is also important. A joint that's moving usually has less symptoms. So if we can keep the joints moving on a regular basis, patients will do better. So after exercise and weight loss, then there's other modalities such as meds that we call non-steroidal anti-inflammatory drugs. The problem with those is that they recently or in the near future are going to all have a label that there's cardiac or heart risk with them. The problem's not that well understood, but certainly there's enough information that it is a concern, and it's not. When we take these meds, even though a lot of them are over the counter, you have to understand that you better have a good reason because there are potential complications with them. After we go from meds by mouth, then we start thinking about injections. And with injections, we have the potential to decrease inflammation. We also have the potential to help thicken the fluid and provide some healing properties or decrease inflammation around the joint. Again, these are temporary measures. There's potential side effects with all treatment options, and certainly with injections there are as well. And the other thing to remember is that they're not going to make the knee joint normal, but hopefully help with symptoms. Another treatment option for certain patients is bracing. Bracing works by applying more stress to the good side of the knee. So typically by development or by injury pattern or by just the way that we stress the knee, one side's going to wear faster than the other side. And that side that's worn can be helped by a brace that's going to apply a tension force and put more stress on the good side. And the final treatment is going to be to replace what's missing, and that's either going to be a partial knee replacement where there's just a specific area that has a problem, or most of the time it's more involved and the whole surface needs to be replaced. The rate of progression of this problem is usually very slow, so it's not something that you need to start thinking about surgery, but you know how to live with it. And then the other thing I think it's important to understand is that we want the treatment to allow you to have the normal quality of life that you want. So if it's not working, you're missing out on things that are important, either family function, work, you know, exercise for your general health. If you're sacrificing that because of the knee problem, then it's better to go to a different type of treatment, you know, is what I would recommend. I want to understand, and our whole team wants to understand what the patient's goals are and outline a plan that includes therapy and may include diet, may include a lot of other things besides surgery, but to bring this package together and make sure that the patient is on track to reach their goals.